Welcome to the Brain Development Podcast. We're here to show parents there is a pathway to healing the behavioural and learning symptoms of their neurodiverse child. And my purpose is to help empower parents to understand how they can build their child's brain from the bottom up to invoke change. And this evening, I am honoured to have Dr. Steffen Decker. He is a UK-based specialist orthodontist with extensive international experience treating children, teens, and adults using advanced orthodontic techniques and functional growth focused approaches. And he's completed his dental and specialist orthodontic training in Germany, Switzerland, and the United States, and holds a Master of Advanced Studies in Lingual Orthodontics. He's recognized as one of the world's leading in invisible orthodontic treatments, including lingual braces and clear aligner therapy, and has been honored the world #1 provider of incognito lingual braces and Diamond Apex Invisalign provider in the top 1% of providers globally. And in addition to that, he is an international speaker and educator, directing postgraduate programs and dental facial orthodontics, and we're going to get into that, and clear aligner orthodontics, serving as a lecturer and scientific advisor for professional organizations and training centers. And he has a clinical philosophy which emphasizes holistic patient development, integrating considerations of functional, airway, occlusion, and facial growth to support long-term well-being and confidence in smile outcomes. And we met through my gorgeous son, Archie, a few months ago. And you've been helping me and Archie on that journey. So I'm so grateful for you to come on my podcast.
It was a very nice introduction. Thank you so much. It's very honored to be here.
Wow. Well, I'm so honored that you're here because when we met, we geeked out quite a lot on functional neurology and airway and orthodontics and tongue posture and tone. And, you know, we talked about what comes first in the developmental trajectory of a child and where does it all start? And it got me so fascinated with our conversation. I said, come on the podcast and share this with parents because I learned so much from that hour with you that I really hadn't considered in everything else that I'd learned in functional neurology. So I would love to ask you, where did it all start for you and how did you get into this?
Well, actually 2008, when I started becoming a specialist, I had the privilege to be trained by a private orthodontic specialist in Germany because they are allowed to train specialists. And when we changed kids' bites with myofunctional devices, she had an osteopath coming in every time to check how the body posture is changing according to the different bites we took.
Yeah.
Which was at the time for me new. I said, what has that to do with orthodontics? I said, look how the body is adapting to different situations we make on the teeth.
Yeah.
So that was for me new, but then I got used to it. So every kid I changed the bite, I had to present to the osteopath, is that correct or not? But then I didn't think anything else. So then I went to university to finish my training. There was no osteopath. So I just did a bit of orthodontic tools, learned about the tools. And then I was in Switzerland for a few years. And then I came to the UK. So in Switzerland, I treated children. In the UK, I ended up being in Harley Street. And suddenly I had no children as patients. So I thought, that's weird. Where's my osteopath? Where's my functional therapist? Where's my speech therapist? Where's my ENT? Where's my support? Where's my body workers in this whole? I don't have them. So I had to focus on adult orthodontics with lingual braces. I became very good in it because there were just no kids. So my philosophy, I actually was learning from the beginning that the teeth are connected to our body. I had to forget. So I focused on classic orthodontics. I took teeth out even, God forbid. I lined teeth. And then about 6-7 years ago, I was approached by a kids clinic in London to run their orthodontic department to build something new. I thought, that suits me. I love children. I want to build something. So I realized now we have tools available with kids like clear aligners, which work maybe better than the ones I used to do in Switzerland and Germany. So that's how it started with doing kids again in UK. But then I did some training in US because my wife is a restorative dentist. And when I met her 9 years ago, she said to me, have you seen your cases failing 30 years after you completed them? I said, no, you attack me. I'm number one in the world in lingual braces, incognito. How dare you challenge me? I didn't say that. I said, what do you mean?
Yeah.
So that you need to go to US to get some education. I said, okay. So I went over to Seattle and met John Coyce. John Coyce told us about this destruction adult dentition and how to rescue it from a orthodontic point of view, dental point of view. So I had to learn the language a dentist is speaking, which is completely different language to an orthodontist, because they're dealing with failures and they have to fix them. But then 2 years later, lockdown happened. I couldn't continue my training in the US. So I got into tongue ties and a bit of what tongue ties have an impact on breathing. So anyway, I went back to US in 2022, finished my training there, and then I realized, John, you know, these adults you're presenting here, most of them are tongue-tied.
Wow.
And that means the tongue sits low. That means the upper teeth moved into destruction. Did you know that? He said, what do you mean?
Wow.
You know, and he's an scientific evidence-based guy. He's the most knowledgeable guy in the US in terms of research. Honestly, John Coyce is incredible. He said to me, I don't know. I said, oh, John doesn't know. Let him send you some papers. So I sent it to him. So I come to realization, okay, the destruction happened because of tongue restriction, which caused the tongue to change, which made the teeth change, which then caused destruction. So then I got into the airway realm of things and thought about airway a lot. And then I realized, okay, when does it start? So then I met, John actually connected me to Christian Leonard, who's also a Coyce graduate. So we were teaching at a symposium in Seattle together, and he linked us together. He said, you guys need to talk. You're both German. You're both from the same area. He does adults, you do kids. I said, oh, interesting.
Yeah.
So then Christian said, oh, we need to look into that. Look, in adults, it's very easy to get data to measure airway problems. So there's research papers that are published that we can measure intermolar distance, x-rays, volume. And then he asked me, but Steffen, what do you see in children? I said, well, that's a good question. So we had a list of evidence-based papers of data in adults, but we had not a lot in kids. So I said, we went back to the list as an adult airway compromised patient has these problems. What of these problems does a kid have in different age groups? So I realized the younger you go in your age group, the less of these problems can actually happen. So we narrowed it down to birth and said, okay, what problems can a child have that is just born? And we came down to one thing: function. Lips, tongue, breathing. So it was 2-3 o'clock in the morning. We had this epiphany. Oh my goodness.
Wow.
It all starts with function. So we started crying. We were so emotional because he said, wow, we just found something out. We have the evidence by using the evidence in adults going back that actually in kids it starts with 3 things: lips, tongue, breathing. So now if you think about it, when does it start? The first thing when a baby is born is it screams. The lung gets open up, we breathe first. Second thing is we get laid to the breast of a mother to feed. These are the first 2 stimuli a child has: breathing, feeding. So generally we can breathe, but sometimes we can't feed immediately because of circumstances. The mom doesn't have milk, or C-section, or emergency, or things happen. So that means already the jaw will not develop forward because we don't have a breast to hold. So the jaw is in a backward position. We get a bottle. Bottle means the jaw opens up.
Yeah.
We don't need any muscle activity to swallow because it just goes down.
Because it just goes straight in.
Correct. So that means the stimulus of using muscle activity to extract milk of a breast is missing. Stimulus missing.
Yeah.
So then some children are tongue-tied. So they can't feed and they can't breathe through the nose because they're adopting a mouth breathing habit now. So now the two stimuli are missing. The nose filtration and air pressure, which develops the jaw, and the muscle activity is not there because we can't feed. So both are inactive. If a severe anterior tongue tie is discovered, they cut it. They get back to the breast, and in a lot of cases it helps because we get muscle activity, breathing activity, fine.
It's okay.
But sometimes that's not the case. And sometimes the mom, they struggle to feed. They wake up a lot. They're getting told, you have to persevere. You have to persevere. It's normal. Try harder. But something is not right. And the mom tells every doctor, but he's not right. He's tossing and turning. He's unsettled. He's not latching well. I have a problem. I have sore nipples. But no, try harder. Because they don't know. But that means something with the tongue mobility, with the strength, is not correct. That means the nipple can't be expressing the milk. So we're struggling. So from the first second we are born, we will adapt to the circumstances we're in. Breathing and chewing. And now the story of life happens. Every year we're adapting, we're compensating in different ways, asymmetries, body posture, and then we're getting teeth. When we have an open mouth posture and the teeth start to erupt, they erupt in a different position than if the jaw's been manipulated forward to seal the nipple.
Wow.
So the occlusal plane, as we call it, is different to an open mouth posture kit to a closed mouth posture kit. So now the minute we get teeth, that is linked to the brain because the teeth get a connection to the brain. And most kids, they can only walk when they have teeth. Because the teeth give neuro to the cerebellum reflexes to give us stabilization. So the occlusal plane we're developing is important for the brain development.
Wow.
So now it starts there. So basically Pedro Planas called it the circle of stimuli from the teeth to the brain and back to the muscles. So it needs to be a connection, a circle needs to be closed. When we are open mouth, the tongue stays low, this circle is disconnected. So the brain gets a different stimulus than when it's connected. So now the tongue stays low, the teeth start to adapt in the upper because the tongue cannot develop the palate. Fact as well is in utero, the palate develops when the tongue basically disconnects from the mandible, the cells, they die, the tongue lifts up and sucks to the roof, and that is how the maxilla develops in utero. So when we are tongue-tied in utero, the palate is narrow. So there's already disjuncted. We can see that in when we do the ultrasound in babies. So it starts very early. So then the upper jaw gets narrow because the tongue can't stimulate it. That means the teeth are coming into different position and eventually the jaw is now drifting to one side. We call it a crossbite. That means the kids use less energy to chew on the crossbite side than on the non-crossbite side. That means the brain thinks, I chew easy on one side than the other, I'm going to just chew on that side. But that means the brain is only communicating with one side.
Yeah. And we
That
also,
only...
we worked out that Archie's side that he chewed on was his weak. He was weaker on the side that he didn't chew.
Because the brain is only stimulated on one side.
Yeah, it's amazing.
But the brain fires back to the whole body. But if one side of the brain is more stimulated than the other side, it has an impact on the whole body. So we have a different stimuli. So what Plana said is that kids who they chew, they use less energy on the side they chew. and all the facial structures adapt to it.
Yeah.
And he showed it in X-ray signs in asymmetries. So now Emilio Lopez, also from Spain, compared it to nasal breathing. He said, children that chew on one side, they breathe better on that side nostril. So if you chew, a kid or chews on the left side, the left nostril is getting easier airflow than the right nostril in children. That means the left sinus is more ventilated, more pressure. That means it grows bigger because there's more pressure in the midface. That means the eye develops higher because it sits on the sinus. Mm-hmm. So when the eye is sitting higher, we're tilting our head.
Yeah.
That means our shoulders need to compensate. Mm-hmm. And that goes all the way down.
Yeah.
In adults then, what happens, that then suddenly the side, because it's so much stimulated, there's a lot of soft tissue, that's a theory, it's not evidence, that it gets more blocked, more resistant, so then we swap to the other side in adults. Mm-hmm. So basically the two things together, breathing and chewing, create two important stimuli to make us adapt. So what happens in children, they are not very good in communicating in what's happening because they think it's normal. I breathe through a mouth, I snore, my dad snores, no problem.
Yeah.
They don't generally have a big problem with headaches, neck pain, shoulder pain, because they're very good in adaptation. But as we grow older, it might not be the case. So now comes a different problem. So when we look at growth and development, when we look at these growth curves, the brain is the biggest organ that grows first in utero and the first few years after birth. Mm-hmm. The biggest thing a brain needs to grow is oxygen. Unfortunately for us humans, the oxygen needs to come through here. Mm. That means the craniofacial complex. If that is not being stimulated well, there's not much air going in there. That means the brain is not getting a lot of oxygen. And when the brain is not growing a lot, it doesn't push the cranial base forward a lot. And that is where our craniofacial complex sits on, where air is going in. So we are more retrognathic. That means kids, when they have less air, what will they do? They will posture forward to open the airway. Mm-hmm. And you can do that for a year. You can do that for 5 years. Eventually, after 10 years, you say, mommy, I have neck pain. Mm. And 20 years later, you get scoliosis or other things. It goes down. That's theory. I'm not the one to claim everything is evidence. It's just common sense of connecting things. Yeah. So basically, what we see in the clinic every day is signs of adaptation. Mm-hmm. And the challenge is to see the signs as early as we can, then we can break the vicious circle. The longer we wait, the more adaptation we see and symptoms, and the symptoms can be so different because if any cells in our body don't get oxygen, they can change. Mm. So if the brain is not provided with enough oxygen, the brain connection, you're more an expert than me in brain, something can change in the brain development, in neuroplasticity. Mm-hmm. But the brain is so clever, if we now intercept in that vicious circle and give the brain oxygen, good structure back, the brain has the capacity to restore as well. And that is exactly the mission. My job is to not just see teeth. My job is to understand that teeth I see are a symptom of something else. Mm-hmm. So the challenge and the thing what I teach is to think that the teeth move for a reason. Is it the tongue? Is it the lips? If it's breathing? Is it tongue tie? What is the reason for this? Because if I can figure that out, I can at least try to navigate the patient parents to the right address to treat it.
Yeah.
And this is the biggest challenge, and it's far beyond orthodontics, what we've been learning at university. Yeah. In university, we learn how to move teeth. Mm-hmm. But if you move the teeth into a certain position without understanding what shifted them in the first place, the likelihood for stability is fairly low.
So they move back.
They move back, and this is what we see. What we are learning at university is you will give them long life retainers. Basically, you say to a structure that should adapt to function, I put you in prison. And you have to be happy with it. Some patients are happy with it, their whole life, no problem, but some are not. So, if you belong to the people who are not, you get symptoms. And these symptoms are not directly linked to the event of orthodontics because they can come a year, 10, 15, 20 years after. For example, I'm not claiming anything. If you take teeth out, that means automatically your space for your tongue will be less than before. So now your tongue needs to figure a way out to adapt to that. Some adapt really well, will never have a problem. But some tongues, they say, oh, I don't like that space. I need to get away from my airway because I have adenoid tonsils in the back. I can't go to the back, otherwise I can't breathe. So I go forward.
Right.
So they go like this. Yeah. So they develop an open bite. Then they go to dentist and say, oh, you have an open bite with gaps. Let's use a magic wand called clear aligners and push them back again. And then we give you long life retainers. So I'm pushing the tongue back. Then I put a prison on, can't escape anymore. Where's the tongue gonna go now? It can only go to the back.
Yeah. Which then blocks your airway, right?
That could block the airway. Another interesting fact is we talked about brain development in utero and post-birth. The second structure that grows most after birth is the defense system, the lymphoid system. So the adenoid tonsils are growing the most till the age of 7, 8.
Yeah.
So now if we are in an environment of pollution and we don't use our filtration mechanism, which is the nose, we might be more susceptible to viruses and bacteria overload.
Yeah, I
so
see
the adenoid,
yeah.
the adenoid tonsils are responsible to protect us. So they will increase. If they increase, they obstruct the airway. So in kids, very young children under 6, 7, the highest risk for sleep disorder breathing is adenoid tonsils.
Yeah.
Because they are growing a lot. So now they have that. They see an ENT. ENT says,
take them out.
I take them out.
Yeah. I've met many kids over the past couple of months, had them out. And I'm like, my God.
So, but then the ENT is not being trained to say, okay, that's only part of the puzzle. Because if you continue mouth breathing or you get more bacteria in our mouth, then they can regrow.
Right.
If they regrow, we just remove them again. So basically, the two parties, craniofacial developers, which is an orthodontist, and an ENT, don't communicate. Because it could be like, I've done my job, I made them breathe, I opened the airway, I removed the structures, but now we need more tongue space and tongue exercises to make them breathe better. That's not happening. So basically, and then what happens is, the ENT, some ENTs say, you will outgrow your tonsils, which is correct. Because if you look at the structure, after the adenoid tonsils, the maxilla is growing next. So in theory, the maxilla will grow forward and down if the tongue is up, and then the mandible will grow forward later on. That means they can outgrow because the craniofacial complex starts to grow now forward, away from the adenoid, but not all the time because it depends where your tongue is sitting.
Yeah.
So that means at the age of 10, 11, we reach something we call a honeymoon period for sleep disorder breathing. That means the adenoid tonsils, they're shrinking, the craniofacial complex is growing, so we have less risk.
Right.
So the kids are fine. But then what happens is, in our society, we don't move anymore. Kids get obese. the BMI is increasing. So we have a lot of teenagers who eat really bad food. That means their chewing stimulus is not fulfilled. They don't breathe properly. They have very shallow breathing because they don't do diaphragmatic breathing. Second stimulus is not there. Yeah. And then they become fat. So what happens is when kids get fat, the tongue increases in size as well.
Wow.
So with the body size, the tongue size increases. So when the tongue is getting bigger, it needs more space. If the craniofacial complex doesn't supply that space, where's the tongue gonna go?
Back.
Eventually back. Or forward, we get an open bite, which we see in orthodontics.
Right.
So if it goes back, so that means in kids with obese, we have more sleep disorder breathing again. And in adulthood, that's the main reason for sleep disorder breathing is when they're too fat, BMI. So now comes next theory. So what's our job? Our job as orthodontists is, I want to call Christian Leonhardt, my good friend, we're teaching a lot together. He made this nice slide. So imagine you drive a Defender car. A Defender car is a nice size car, and that is your tongue. So it is driving on the road and it wants to park in. So the parking space is your palate. So in order for the tongue, the car, to move into the car park, the space, you need an engine, which is your muscle.
Yeah.
So if your muscle is not strong enough, the Defender will not move in any space because it will move. But if the car space, the parking spot is too small, the car will not fit in either. So now my job is to give the tongue enough parking space so it comfortably can park in. But then I need to also give the car, give it a good muscle at the engine to move. But then we forgot one thing. Sometimes this car is towed to a wall with a string. And that string can be a rubber band, a tow, or a chain, which we call a tongue tie.
Yeah.
So we also have to check, okay, now I provided the car with enough space to park. Now I sent him to a myofunctional therapist to give a good engine. And the myofunctional therapist needs then to decide, is my engine strong enough to stretch that restriction to park in or not? Then we need to release it. So only if all three of them are fulfilled, the tongue can park in the right spot.
Right.
When the tongue is parked away, the traffic can flow.
Yeah.
Which is the air.
Yeah.
So it becomes super complex because if there's a lot of traffic because of obstruction in the nose, we can't have also nice traffic. So it's a super complex airway problem. It's multifactorial. And this is the biggest problem, that all parties need to work together and speak the same language. And we don't have the same language. A dentist has a different language to an orthodontist. An ENT has a different language to other people. We don't have the same language. And from a brain development, all of these adaptation mechanisms, the brain needs to deal with. And sometimes we adopt well, but if our lifestyle is changing so much with food, toxins, heavy metals, all these things, our brain can't flush the toxins out.
Yeah, because you've got your filter paper in your nose and it's correct. It's stuck.
It also has its own drainage system. Lymphoid system is alone in the brain. It's separately. So if we get all these stimuli over the day and our brain can't get rid of it because our sleep is disturbed, then our brain gets overstimulated, can't deal with it. We have more anxiety because the toxins have never escaped. So now we have a society problem of depression, autism, ADHD, and all the other things, which we clearly see in research papers. So there's now, obviously we talk already so deep. Most patients who come to me, they come for teeth because they think, oh, my teeth is crooked. For me, I don't care about your teeth. I care about what made them move because this is the underlying issue. And when I then start talking about how is the kid sleeping, is it moving at night, is it snoring, is it struggling at school, you get the real story of the child. And you get a story that children are struggling. And that means when you give more parking space for that car, and then you refer to someone who trains the muscle, the engine, gives a good engine, and eventually you have someone in your team who cuts the chain in the back, you realize, wow, suddenly traffic can flow and symptoms go away. And when you realize that, it opens your heart. Because you, with your decisions, you not change the teeth. You changed a human being and their life trajectory. Because you know, which John Coyce told me, if I'm not intercepting right now, they will have a whole life of dental issues potentially, cost them a lot of money. Forget the mental health issues. That's just tooth related. I know the adults have a life of adaptation compensation. Their dentist, single tooth dentistry, fix, spend a lot of things. And when I came to the realization with Chris, and we said, wow. We, in our profession, have a huge responsibility. And we brought that knowledge back to John. And since we did that, John is our biggest supporter. He changed his teaching.
Wow.
So he said, let's put Airway first. Because what's the point of putting beautiful teeth and veneers on someone if they can't breathe? So everything is changing now, slowly, coming a lot from the US. And unfortunately, in the UK, there are more resistance to it because they want to be evidence guided. There is evidence out there in different magazines, maybe not in orthodontic magazines, but in brain magazines, in sleep medicine magazines, in more holistic magazines, there's papers published. But they also say about it's not evidence-based medicine. But if we look at what does it mean, 1996, Sackett published the article, What is Evidence-Based Medicine? And it's three things. It's clinical trial, research and control groups, but it's clinical expertise and patient feedback. Three things: clinical expertise, patient feedback, and research. What do I do if there's no research? Me doing clear aligners with body workers, myofunctional therapists. What if there is no research? The only things that are left for me is patient experience and my experience. And what I see proves me right. So I have my own evidence, which people not calling evidence-based because I don't have control groups. I don't treat identical twins where I have the luxury to say, you get treatment from me, you don't. And we see in 20 years what happened. How do I do that? So this is where we're at currently. And it's sometimes quite sad because people try to fight you, attack you, but they don't actually understand who I am. And what I want to do is help children. My mission is to help children to spread the word that things can be done. I'm not saying I'm helping every child to breathe, but at least I try to what makes sense to me. I can change. I can give them more parking space. I can send them to myofunctional therapist to give an engine. I can take the chain away. I can't look into the nose. I can look at it, but I'm not allowed to diagnose it. But I can get some ENTs on board who are allowed to do that. So overall, this area is not that big. It's a nose and it's a throat. So that's two people, myofunctional therapist, ENT and me, and a dentist. That's not that much. So I'm sure we can talk to each other and holistically together look at the case. And like Chris and I said, the earlier you catch it, the more it's the lips, the tongue, or the nose.
So with the parent that has a mouth breather as a child, and I see them every day, I speak to parents every day, and they, I ask the question, and I haven't stopped talking about you since I met you and Yuli, and I've referred loads of people to you to look you up and to go see you. You've got somebody this week coming to see you, and I I am, so grateful for the work that you're doing, because you can correct mouth breathing early. And like you said, the earlier you get them, the easier it can be.
Well, let's talk about this. First of all, it's about figuring out why do they mouth breathe. It could be as simple, they had a cold, they couldn't breathe through the nose, they breathe through the mouth for a while, they got used to it, and they never changed back. Okay. Then it could be there's something in the nose obstructing. It could be a deviation, could be a valve, conchate, turbinates, whatever, that's in ENT. In a lot of cases, like I said, in children, it's the lymphoid system, the adenoids and tonsils.
Right.
There's a viral infection in 95% of cases, which makes them grow. When they grow and obstructing the back of our airway, their mouth needs to open its protection. So they're adapting mouth breathing habits. So I would not say that I change mouth breathing. But what I would say is, if I see there's something obstructing in the back, I would refer to an ENT who deals with it. With a really direct referral, there is something. So don't fob them off with a nasal spray. Yeah, I see something in my x-ray that is obstructing. So then they can't do this and say, nasal spray, bye-bye. Yeah, so, but it's a challenge, because when I interviewed David McIntosh in Australia, he's an ENT for Pediatric, a very, very good guy. He said to me, Steffen, when you hurt your shoulder, you're going to a surgeon, correct, to fix your shoulder. But will you go to a knee surgeon to fix your shoulder? I said, what do you mean? He said, you will go to a guy who specializes in the shoulders, won't you? I said, yeah. But what people do when they hear ENT, they go to an ENT who might be specialized on the tongue, or an ENT who might specialize on an ear. What you need to do is you need to find a pediatric ENT who's focused on upper airway.
Right.
Which is a whole different specialty in ENT, which I had no idea. So that means it's not as simple as saying you need to see an ENT, because if you see an ENT who's focused on tongue, he gives you a nasal spray.
Yeah.
So it gets so complex, and you need to, over the years, when you do these podcasts, which are so great to connect, you learn so much. It makes so much sense. Okay, now when I ask for ENT, I ask, who are you? Tell me, what is your specialty? And if they say airway, great. If they say adults only, maybe not so great. Because I don't want kids to have 10, 15 episodes of tonsil infections a year for them to say, okay, maybe we should do something. Because my son was that child. My son had tonsil infections every 4 weeks. They had kissing tonsil, he reacted with fever. No ENT could help him. So for 4 years, I was in A&E every month. And I didn't get anywhere until I got a diagnosis of periodic fever syndrome. Great, I have a diagnosis. Didn't take the symptoms away of him not breathing properly, not sleeping properly, not eating properly, losing weight, going to A&E. That was hard. So until I found an ENT who knew that syndrome, who said they need to be removed now.
Right.
So we paid privately, removed them, and he has never been ill since.
Yeah.
Surprise. And what I did, I developed his craniofacial structure, now with aligners and now with braces, the last few years. So he's fine. I taped his mouth, I trained to breathing through the nose. So I did everything I knew afterwards, but I don't give any blame, because I was a parent as well. And I didn't know.
Yeah, I know. And this is what the podcast is about, to actually get this out there. And so many parents are thanking me just for the people I bring on that are giving that information that you just don't know about until you just start listening a little bit more to understand.
And you don't know, and you feel guilty that you didn't realize that.
I know.
But I hear that every day, and every day we have some emotions in the room, because moms feel guilty when I tell them all the talk, duck, 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 duck. It says, how did you know all this?
Oh, I cried
And
because I realized, and I felt so, so guilty that I hadn't done this
but
earlier.
this is nobody's fault. Even the dentists who don't know it, it's not their fault. They just haven't heard it yet.
Yeah.
But what I do blame people for is if they don't want to enrich their mindset and are closed off and don't want to listen. And they just say, no, there's no evidence. Please, the intention we have is to educate, to help parents to get help. And I can tell you so many stories. I want to tell you another story. So now we know that the craniofacial complex is very important for kids to breathe. So let's talk about Down syndrome children.
Yeah.
So Down syndrome children, a lot of them struggle to breathe. They have CPAP machines, high pressure machines to get oxygen down there. Also, they have been told their tongue is too big. So how about if I would say the tongue is not the problem, the craniofacial complex is too small to fit your tongue. So your tongue is fine. It just has a very low tongue tone, no engine, and there's not enough parking space for your tongue. So, but now, to the nose, there are also some connections. In the nose, ending the ear canal. In the nose is ending the tear duct. So, I have Down syndrome children. It might be coincidental, but I don't want to claim anything. So, one kid with Down syndrome couldn't hear properly. So we opened the palate. Suddenly he had movement in his inner ear. Wow. Emotion. I said, huh? I just did open the craniofacial complex, widen the maxilla because there was a crossbite, a symptom, and he could hear. Then I had another Down syndrome child. His tear duct was blocked. He always had tissues to wipe his tears because they couldn't escape. So that was 2 weeks ago. Mom came to me. We started expanding the palate. Steffen, it's gone.
Wow.
I said, what do you mean? The tear duct opened.
It's life-changing.
Huh? What do you mean? So I did research. I said, huh? How is that happening? So I realized the tear duct is ending in the bottom of the nose. So it makes sense. It's very close to the area which are widened.
Yeah.
So I thought, is there any evidence? No. I looked at the up in me. Is there any evidence? No. But there is evidence that more airflow opens the ear canal, which can help. And there's also evidence that ENTs say when you widen the maxilla, you need far less grommet surgeries.
Right. I
That's
hear
from
lots of kids. Yeah. So I have lots of kids that have grommets.
Yeah, so that's nasal breathing. So through Sagi in LA, he never places grommets, he expands and does myofunctional therapy.
Wow.
That's his protocol.
Yeah.
So here's an ENT who changed his approach, says, okay, there's bacteria, let's expand into myofunctional therapy, and that helps them. So if you listen and read all of these things, you say, dear mom of a Down syndrome child, I can't promise you anything. I can give you more parking space for the tongue. That's my job. But potentially, it can help you in other things, which I have seen, but I can't promise you because it's multifactorial. All I'm saying is, I can help you to give more parking space for your car.
Yeah.
My team can help you to give you a good engine, and my team can help you to eventually get the chain off your back of your car. Then I have a team who looks at the nose. So in a team approach, we can potentially improve symptoms for your child.
Yeah.
Isn't that the right direction?
Definitely.
Then instead of saying, no, there's no evidence, come later when you have so much problems that we actually do something.
Yeah. And then you're not really going to fix it because you've still got all the other issues that are still there.
But you have probably more symptoms than before because you waited.
Yeah.
And this is what I hear in the whole world. Wait and see.
Yeah.
Wait for what? If you know adaptation and symptoms, you have opportunities to intercept. I'm not convincing parents to do it. It's not about money making. It's about giving parents an option a choice to say, this is what I can offer you now. I'm not helping, I'm not promising you the world, but this is what we could do. If you want to do it, fine. If you don't want to do it, fine. But please come back if one of the symptoms I mentioned are happening.
How about those non-verbal children? How about those?
I'll talk about that in a minute. Hold on.
All right.
So now I tell in a kid, this and this and this can happen to you. But it's fine if you want to wait because financially, whatever reasons they have, this and this can happen to you later down the line. Guess what happens? Mom and dad raise their hands and says, excuse me, it's me. I am the one you just describing. I said, surprise, surprise. I had this. So you have adapted now. How are you feeling? And then most of the time we say, bad. What can I do now? So I said, okay, now it gets expensive because compensation is the tax you pay when prevention fails.
Yeah.
So now to your question, nonverbal. So as we know by statistics, autism is on the rise. Mm-hmm. So 1 in 36, 1 in 30 children, something like that. And I did a podcast last week with Taiba Baha. Yeah. She wrote a book, Unlock Autism. So she says about the 7 steps that parents can do to potentially help their child with nonverbal autism, because she had one of them, her own child. Yeah, it's about heavy metals, gut, oxygen, so all these things. So now, fact is, I want to develop a bigger parking space. But these kids sometimes don't have the capacity to sit still in my chair.
Yeah.
I can't do records. I can't do diagnostics to be legally safe to see if I can help them. Mm-hmm. But what I can do is to say, dear mom, there are people out there who can do it by helping you changing the diet, getting movement going. It can be that this way we can help your child to deal with the environment we are in right now better, so that I can do diagnostics and I can give more craniofacial structure for them to get better engine, more car space and release the chain. So, but it's sometimes a journey and I'm sometimes not the first person to see. So I'm very open. Sometimes it's an ENT, sometimes it's a myofunctional therapist, sometimes it's a body worker, sometimes it's Taiba, sometimes it's you. It's all about helping each other, loving each other, and try the best for the child. If I'm not the first point of call, that's fine. I don't need to be, because guess what? They will come back.
Yeah, and you need to, I think with how I work with the patients that I see is that you need the right team. There's a team of people that you need to put around you, and you would be with Yuli and my behavioral optometrist friend that's not far from you.
Absolutely.
Like all of these people are part of the team, and they're going to help your child get to that point of functioning. That it's in time. It doesn't all happen within 6 months. It happens over time.
No, it's also, look, how much can a child deal with at the same time?
Exactly.
In theory, we can do this and this and this and all, and then the child feels like I'm a big problem. Big problem, anxiety. Because they're all, so you have to see which child is sitting there. How much can we actually do at the time? And one small step in the right direction is good.
Yeah, absolutely. So with the babies, we go right back to the beginning of our discussion, because I know we haven't got much longer and I want you to have your evening. With the babies that come out it starts with function. If those babies are mouth breathers from the start, what could you do then?
I give you another story. I had a child, 4 years old, came in with me for an opinion, severely tongue-tied, a clear mouth breather.
Yeah.
So what I expected to see was adaptation, which means narrow palate, high vaulted palate.
Yeah.
But I didn't. So I was very confused. I said, huh? The tongue can't go up. The cheeks must push it together because he's not breathing through the nose. I was very confused. So after the diagnosis, I said, Mom, I don't understand it. What are you doing? And I always ask this question now because I learned. What's your profession? She said to me, I am a craniosacral therapist.
Oh, wow.
I said, what does it mean? I said, because I know the impact function has on structure, and I know my son is tongue-tied, I know my son is mouth-breathing, I massage the palate of my son since birth.
Wow.
Every day of his life. I said,
Wow.
Okay, if the tongue cannot stimulate the palate, my finger can.
Yeah.
So what I do now is,
amazing.
In every child, when I had an 18-month-old Down syndrome child coming to me, obviously I can't treat, it's too early.
Yeah.
I put my finger in his mouth and I started rubbing, stimulating the parasympathetic nervous system. Because that's up in the palate.
Yeah.
Heart rate drops. Suddenly, the kid starts moving the tongue.
And starts sucking.
That's myofunctional therapy.
Wow.
And I do that the whole consultation hour I talk.
Yeah.
Suddenly, the child falls asleep. Because we're stimulating the part. The mom says, huh? What are you doing? He never sleeps.
Wow.
So I thought, yes, it's so working. So to answer your question, if we cannot get natural stimuli, we can give them the stimuli. Give them something to chew. Yeah. Stimulate the palate.
Wow.
Because when we have good muscle activity and there's just a restriction, guess what? We trained the engine, then you release eventually, and the engine is already trained.
It's so simple, Steffen.
It comes down to lips, tongue, and breathing.
Oh my God.
3 things.
It makes me feel really emotional. Like, that's what I could have done for my own child, knowing that he was a mouth breather. I could have done that every day.
Basically, what I say now to parents, Dad, you can't feed your child. You probably don't do a lot because it's very hard for dad to be connected with a young baby. But what you can do every day, take your child, start to lick your finger, massage your palate.
Yeah.
What you get out of it, they look into your eyes, they calm down, that movement, they're sucking on your finger, which is a beautiful feeling.
Yeah.
And eventually they fall asleep.
Yeah. But you're also, you're helping their whole palate develop by the ability of that motion too.
So this is prevention.
Yeah.
And prevention starts very early. And prevention starts then also to say when a mom wants to conceive, check sleep, check their oxygen. So in kids that mouth breathe, I don't say, please I don't say cut all tongue ties. Please don't. Because if the engine is not in the car, you can cut whatever you want in the back, it's not moving. And if you cut a tongue tie and it basically gets scar tissue in there, you make out of a rubber band a chain.
Right.
And then the tongue is much harder to move.
Right.
So not every tongue tie needs to be cut.
Right.
It needs to be assessed. Before you cut, you need a strong engine. Otherwise, the car is not moving. How you make the engine big, that's your choice. But you need stimuli, chewing, breathing stimuli. This is all you need to do. If you can't give good food because you can't breastfeed, you need soft diet, you can give them something to chew.
Yeah.
Yeah,
Like,
there's Munchie, there's a lot of things out there.
Yeah. I was talking to a mum today about the Munchie and how, she could give her child, because their child just eats everything, chews everything, because it's got the rooting reflex is very, very strong.
So now you mentioned another thing which I came to realization more and more when you do these podcasts is primitive reflexes.
Yeah.
There's so much that the primitive reflexes can't develop properly. They don't set. This is your area.
Yeah.
So this is something we need to consider like, this is not my expertise. This is where you come into the game. So a lot of primitive reflexes are not developing anymore. Why? Because we get helpers to walk. We get all of these helping devices. So they're skipping natural processes, which is not good for our brain development. It's just, the more you dig, the more you discover what you don't know. And then you think, oh God, what's next? But the reality is that I talk on that level I just did. It never happens. Because the people coming to me coming for teeth. If I talk about primitive reflex when they're coming for teeth, they think I'm bonkers.
Yeah. Well, they don't put it all together. And unless the mum you're going to meet this week, she's put it all together. She's one of those power mums, and there's a bunch of them that follow me and are in my circle, and they're all end up coming to you. But some of these mums have put it all together and do listen and understand it. It's a whole body approach. It's not just not one thing.
No, but isn't it sad that it's so simple? And
yeah.
And lastly, I want to tell you another story. My wife is Indian. She's from Punjab, North India. And last year I had the privilege to meet her family from there in a rural area of Punjab. There's nothing there.
Yeah.
Hardly any televisions. There's no windows. It's all open. So her uncle lives there forever. He's a doctor there in the village. He's very much appreciated. The whole village gives him food, everything. So I got a lot of love. But what I wanted to say is, I woke up at 6 o'clock in the morning, and I've seen her uncle sitting in the living room doing his breathing exercises and yoga exercises with the tongue.
Yeah.
And breathing through the left nostril and right nostril. So I was sitting there for a good half an hour, admiring, thinking, this is what I teach. I get money for this. So I said, what are you doing? He said, well, I do that since I was born. I wake up at a certain time by sunrise, go to the temple, show appreciation, do my walks, my steps, say good morning to the sunlight. Then I go home and do breathing exercise and tongue exercise because it clears my brain.
Yeah.
So I was thinking, oh God, so simple life. So powerful, because we did some charity work at local schools there. And I looked at the kids. Of course I did. There were not many problems.
No, because of their simple life. Yeah.
So, they have good food, they have good sunlight, they have a lot of things right, lifestyle. Like there's Beth Lambert in the US who has a page documenting hope, who helps also a lot of children with autism and ADHD. She always talks about lifestyle, the impact it has on our children. You don't need to have everything in life to be healthy. You need some basic things. You need good food, you need sunlight, oxygen, water, and air. If you don't have these things, you need a doctor, a different doctor. So, it can be very simple, but we are so busy people. We live in an area of London where everything is fight and flight, run, forest, sympathicus nervous system overload, gaming, the stimuli of different devices. It's hard for our children. But what we can do also from parent perspective is there's sometimes a device-free zone, talk to your children, move them. There's so many things, but like what we can do is I can give you more parking space for your tongue. And the other team members, they give you an engine and maybe restriction, but there's ENTs as a whole lot. But only together we can make a difference to the society. And this is why we're sitting here talking at 9 o'clock in the evening on a weekday, because people need to hear it. And lastly, I'm not here to attack my professional colleagues. It's not about that. I just try to make sense, to connect dots, and to help children where I can. And sometimes I'm not the first person who can help them. That's fine. But I don't claim I am. So, but fact is, I see more and more problems. Autism people come from the whole world. So we need to start a bit opening our eyes to a bigger picture of what's happening out there. And if it's your princess or your prince sitting there struggling with life, maybe you think back to that podcast and think about it. Or maybe I, go to him and get an opinion. That's my wish. I'm here to support anyone I can. And with my teaching, we have the Academy, the Orthodontic Specialist Academy, to teach our professionals to see, to diagnose, to see the first signs. Lara, I'm so grateful you came to me, that I can help your kid now and I can help you in your story. I feel good doing this, and thank you for everything.
No, I appreciate the fact that you said yes to come on the podcast and share, because so much of what you've explained will put so many people in a position to connect more and more dots of what they're seeing in terms of their child and what they're presenting as. And all I'm trying to do is bring the right people to help as many parents as I possibly can. So, Steffen, I'm eternally grateful. And I've picked up with Beth Lambert, and she's coming on my podcast, and we're talking about how I can help her in her conference that's happening in October and going to Florida, and how I can help her in teaching some primitive reflexes
I'm
to parents.
so happy that another connection is done.
Absolutely. All part of the team. It's the whole web of us trying to make a difference.
Thank you.
Thank you so much. And if you've really loved listening to this, then please do go on and subscribe wherever you're listening from, because there's plenty more of these to come. Thanks, Steffen.
Yeah, if you need also my information, I'm the orthodontic specialist on social media. My teaching is the Orthodontic Specialist Academy. So follow me, follow us, and we will continue. Keep us updated with your son's journey as well.
I will do. And all of your details and how to connect Steffen will be in the notes. So you can definitely connect with him if you want to have a consultation. Thank you.
Thank you so much. Have a nice evening.
Thanks.